My name's Mel Hall and I'm Head of Service for Primary and Community Mental Health. So welcome to our session looking at what social work is for primary and community mental health. There's a little bit of housekeeping. So if you can go to the next slide for us, please, Ardil. We have got a legal disclaimer and privacy notice. So we are an independent that's doing the work with Social Work England this week. And so if I can draw your attention to the disclaimer that the only views and the information and opinions expressed by third party during Social Work Week are the speaker's own and do not necessarily reflect the views of Social Work England or its employees. Social Work England have not endorsed third-party content, and Social Work England accept no liability for the content of the third-party or independent session held during Social Work Week. So it's kind of nice they haven't had to sign it all off. So the next one is that if you go to the next one, we've got event etiquette. So during the event, due to the nature of the complexity of social work and content, content of some of these sessions may be triggering for some people. Please be mindful of this and take whatever steps you need to take to look after yourself. Please be respectful of others when contributing, and we reserve the right to remove people from the meeting if behaviour is inappropriate or disruptive. So thank you very much. If we can take that down, please, now, Ardil. So good afternoon, everybody. As I said, my name is Mel Hall and I'm Head of Service for Primary and Community Mental Health here in Sheffield. I'm a registered social worker and I believe I'm called a lapsed AMP, which means that I was once a approved mental health practitioner. My background is commissioning, national policy and public involvement. I'm going to ask you guys, for those of you who are not on panel, would you mind please turning off your videos? What we're wanting to do is simulate what we talk about on our monthly supervision sessions. So I'm going to ask each of the social workers to please introduce yourselves. So I'm going to go first to Becky.
Hiya, I'm Becky Bollington. I'm a mental health practitioner within the service, and my background, I was an adult social worker in localities team.
Thanks, Becky. I'm going to go to Savi.
Hello, everyone. My name is Savi. I'm a registered social worker with international experience working as a mental health social worker in primary care settings.
Thank you very much, Savi. Carolyn.
Hi, my name's Carolyn Seaton. I'm a mental health practitioner and social worker, and my experience is in the secondary mental health services, integrated mental health services for 20 years.
Thank you, Carolyn. Nahid. Oh, you're on mute.
Hi, my name is Nahid. You've got me. I've unmuted myself now. Hi, my name is Nahid. I'm a mental health practitioner and a social worker, mental health social worker. I've been working in mental health for over 18 years. I also work as an associate lecturer as well. And I've been a social work practice educator for about 17 years now as well.
Thanks, Nahid. And Lauren.
Hi everyone, I'm Lauren. I'm a mental health practitioner within the Universities Network. I'm a registered social worker and a registered AMP as well. So I've got experience in adult local authority, adult social care, mental health and learning disabilities.
Thank you very much. So for our audience, to give you a bit of an overview of what primary and community mental health services are like in Sheffield, the service in which we all work is a new service which is part of transforming mental health services for adults. And what it's doing is bringing together primary care and secondary care so that more interventions are provided to people which have got serious mental illness, or SMI you might hear us referring it to. And historically, these are people that would not have had access to secondary care services because they were not at such a high risk or complexity, but they weren't able to access interventions through talking therapies. So what we're going to do this afternoon, in the next hour, is simulate a supervision session we've had as a group where we are trying to understand what is the social work role in this new setting? What is it that makes us unique? How do we bring our values and our professional standards into the service? And to do that, we're going to ask ourselves 3 questions. At the end, there is a question that has been pre-submitted, which we'll also look at. So the first question I'm going to ask the panel is, what have been the key challenges for delivering this service from a social work perspective? Becky. And you're on mute. I think we've all got to do it once, right?
I thought I'd pressed it. I thought it was all right. So one of the first areas that we spoke about within key challenges is around loss of identity. So in terms of within my previous role, social worker, you kind of assessment and care management, it had that set process and knew what you were following. And then when coming into this role, although still registered social worker, the title of being a mental health practitioner with a social work background, you're still social work based, you still social work values and kind of more treatment based, rather than that focus on the title of being a social worker and the kind of coming away from that care coordinator type role.
Yeah, absolutely. Carolyn, how have you experienced it?
Yeah, so as mentioned, my background is in the integrated secondary care service. So yeah, for me, a change away from care coordination, from the care programme approach, but I am, however, aware that has, whilst I've been here, ended. And the focus now is on interventions, which is exactly what we're doing. So in many ways, I feel that we are really sort of, fitting in with the new models, new ways of doing things. A lot of emphasis on flexibility and on local accessibility as well. So it fits in really well with that. Also, in terms of loss of identity, the obviously the AMP role very clearly defined in secondary care. So that not being around, I do think that having AMPs in a service kind of adds oomph to the social care model. Their senior staff were kind of used to taking an independent view from medics. So not having them around does, I think, change slightly the culture of an organisation. So I've been aware of that as well.
Yeah, interesting. Naheed, have you got some more to add about that medical approach and how maybe it's different?
Yeah, definitely. And I'm just, if I can just take a step back, just in terms of what Carolyn said, actually, I think that was quite interesting because me and Carolyn worked in secondary services for quite a while. And there are still some elements, I think, of not just the medical side, but the social intervention we will still use in secondary services as well. Not as set and grounded as much as it is in primary care, but I think we still had that element of social work, definitely in secondary services. I don't know, Carolyn, if you felt that, we were still using the interventions in secondary services when we were working with individuals. I think it was more kind of when we were in MDT meetings, it was more, you had more individuals come from a medical model perspective than they were coming from a social model perspective, especially in MDTs. But that was just an add-on to what Carolyn said. But yeah, in terms of what you're saying, it's me moving on from that, I can chat, what I'm like. My colleagues are aware I can just go on for ages. Yes, in regards to the medical model, it comes in terms of fixing things. In terms, it might be individuals might say take a tablet, cure this. Well, we come in terms of our intervention, in terms of social work, we look at different perspectives. For looking from a social work perspective, we look at interventions which we use intervention like strength-based approach. We individuals look at its use. We do definitely use systems theory. Systems theory is more very holistic assessment and an approach is not just looking at there's something wrong with the individual, but looking at the individual's environmental factors, who's in their actual environment, is it family, etc. What's other individual, what can we move around to actually make this system flow? So that's quite an important approach we use in primary care in our interventions.
Yeah, definitely. I think yeah, what we kind of talked about there is about that loss of very clear roles like assessment and care management and AMP, but you're quite right, it's then what other people are thinking we do, and of course it's not just about using that model of fixing, and it's about, as you rightly said, about influencing and helping people to understand where they are. And we do lean on the social model there.
Definitely. And I think Melanie, I don't know if you, I mean, what I also know is moving from secondary services and then primary care. This is me adding on loads, and I carry on. You don't have to tell me to stop. You know what I'm like. I can just chit chat. What I noticed as well is that the teams we're in now, in terms of the networks across in the primary care, is that we've actually got we've got quite a stronger team. We've got more of the equality there in terms of individual workers, professionals coming from a social work, working from a social work model. We've got workers like connect workers, support workers, you know, a lot more coming from a social work perspective, which we didn't have as much in secondary services. So there's that equality. I think we're getting that in terms of professionals in a multidisciplinary team as well.
Absolutely. One of the things was about the system that we used as well. So Becky, Lauren, was there something you wanted to say about the System 1 ledgers that we use System 1, which it's a primary care patient administration system?
Yeah, I think Becky will probably agree with this. We've discussed it before, in that the system is a very medicalized system. So a lot different to the kind of the systems that we've been used to using in social work. So it's kind of like everything's very appointment based, and it kind of solely reflects the direct work that we do with patients. So in terms of what we record, how we record it, how we record the patients or the service users' views, and the circumstances is often different, and it's about trying to record that in a way that still reflects our values and what we've observed, but making sure that what's happened is recorded. And I think the challenge that we've previously discussed is not writing too much, knowing how much to be right, to be succinct, but you know, making sure that the person's journey is still captured within that.
Yeah, I agree. And for me as well, I came from adult social care, so a lot different system, coming into a very medical system. It felt really daunting to start with, and that ledger-based work, and very much kind of really structured on that medical side of model. And actually GPs or people wanting to kind of book into those slots, and your time slots are very kind of set out. It was a different approach to than kind of what I'd had previously. But the more you get used to it, the more helpful it is, and the more you can build on that and make it work. But it was definitely a big challenge and a big change. I mean, learning a whole new system anyway is always fun, but it was that thing of it being a really different approach, and similar to what Lauren just said around how much we write and what we are writing and what we're including, going from kind of very detailed work, very kind of a lot of information needed to be recorded, and then it's trying to reteach yourself what's needed to be there, what's important, what is important. And kind of I still feel I can still write quite a lot, but I still am quite selective on what I choose to write, and it's just making sure that the things that are in there are the important stuff.
And I think following on from that, a main challenge for me is that the system only you can just write the direct work with the person, but it doesn't encapsulate the work that we do outside of that. So the discussions that we're having constantly with our supervisors, with colleagues, and how that informs our practice, I find that missing from our previous kind of social work systems. But yeah, I think, like you said, Becky, it's an ongoing challenge, and we're trying to make that work, and we're developing on that.
Definitely. And I think what I've come across as well is that when we are having them slots and doing that set structured work, it actually feedback I'm getting from the service users are actually they know what's happening. They know when their appointments are expectations as well. They know how much, you know, sessions you can do with the individual. They know that, you know, it's continuous work. It's a same named person as well. And they've always wanted that. And I think that they really appreciate that from the feedback I've got from individuals, and it's set for them in that way. Definitely. It says no, it's not change of work and not saying the same thing again and again or ask the same questions. They know who it is, they know who they're going to see and when they're going to see him, and they like that from the feedback I'm getting. Definitely.
Wonderful. Yeah, and I think so one of the things that for the audience is that we work in into GP practices, which are into primary care networks, which are a group of GPs that come together, and the way that we have brought together the intervention sessions for patients, for people, is that we're clear about how many sessions. So we'll do specific work with people. And you're right, I think sometimes the systems, the system one is very medicalized, as in it's appointment, you turn up, you come. But what I think you're all talking is saying that actually some of that's are really beneficial because patients know what to expect, when to get it, and when. But then it doesn't stop us from being able to be social workers and use our values and interventions in a way that makes sense to both patients and ourselves. Fabulous. So what do we think around that, the primary care culture? So we've talked quite a bit about the practicalities and about how we get a sense of ourselves. How are we finding the primary care culture in relation to social work? But Naheed?
I mean, in terms of like just kind of what we talked about, the sessions, you know, having the structured sessions for individuals. And I think it's more kind of when we're screening and assessing individual at the initial stage. I mean, obviously, we're still doing the social work element, which is, you know, is ingrained in us as social workers about the assessment process, screening, which we do at the initial stage. And it's working jointly with this, you know, the service users who we're assessing, you know, saying that, you know, this is what we feel, work with us, you know, what do you feel that you want from the service? A very person-centered approach we're using. We were doing a lot of joint working, you know, we don't see it, we're sharing that power. So there's not that power imbalance between us and the service user. It's like, so it's kind of saying that I feel it's this is my professional view, but what do you feel that what do you want from the service as well? And then setting the structured sessions with them. Yes, we do have set structured sessions, and it seems like it's very like a process led, but it's working, like I said earlier, is in terms of the individuals knowing who the worker is, when the appointment's going to be. And also it is in discretion as well. It might be that we set out to do like some trauma informed work with someone, you know, that's something that's come out, and it might be end of the work, when we're coming to the end of that, it might be that the individual needs a further few more sessions, and that can be joint work with you know, with the individual and saying, look, you know what, let's look at something like, you know, let's look at safety planning, or look at other services, what we can refer you to as an exit plan, making sure the individual doesn't actually get lost somewhere and there isn't a gap in terms of services. They're left with nothing in regards to their recovery journey, and that's really important. And this is a lot of this, what I'm actually saying is not just me as a profession saying this is it. When I'm working with individuals, you know, the feedback I'm getting is, you know, and we are getting as a service from what I'm seeing. Is that right, Mel? We are getting that kind of feedback.
Yeah, we use a PREM, which is a patient reported experience measure, which has been created within the service with experts by experience, people with lived experience, to kind of capture not just what we are saying is an outcome, but what patients say how they've experienced the service. So that's for a short on word, it's a PREM. And at the moment, yeah, the score we're kind of getting out of 5 is 4.6. It's really sad. I know that, but one would hope I don't know that as the head service, right? But yeah, we get a lot of positive feedback, and of course, there's always areas that we can improve. One of the areas is about what we've seen as culturally different, I think, is about reflective practice. Savi, is that something that you've come across?
Yeah, I think, you know, when reflective practice is, you know, is always, I think, beneficial to us, but also it is more for the patient and for the service that we provide. So I think, you know, making time again for these like medical structure where you have set timetables for everything, but in a medical model, I think there's not a lot of room for that, to go through that reflection, the work you're doing with the patient, their feedback. So I think it's really important to somehow make that time wherever you can. And it is, I feel like, difficult at times, but you know, it's, as social workers, we're good at like advocating for the benefit of our patients. So I feel like it's something we're currently doing in MDTs that I'm attending, that I've had one earlier today. It's really beneficial.
Yeah, that reflective practice. Yeah. Come on. Sorry, Becky.
I was just going to say, just to add to that, there's different levels with the reflective practice as well. So obviously we have the social work supervision reflective areas, and then there's ones within the team as an MDT as well. And I think those practices and those sessions allow for different professionals to have different viewpoints, and they're the ones that can sometimes easily get a little bit lost, and that kind of like luxury of a supervision session and those kind of connections can get lost with people get too busy or things like that. But I think as a team, I know our team really have started to value those opportunities to come back together to kind of rethink and regroup and evaluate situations or reflect on situations, and actually going forwards, how can we change and improve? And that kind of really in-depth reflection really makes a difference. And that kind of, I know we've mentioned it a couple of times, but consideration of power and lots of different conversations go on that you don't get in your general conversations in passing or things like that. So they allow that space to really develop that further thinking.
Yeah, definitely. And I think I hear back from within the primary care culture, and for GPs, for example, the thought of having time out to be able to do reflective practice is sometimes seen as a real luxury, which I guess sometimes can put things at odds when, you know, we're quite used to having reflective practice and time to be able to formulate the way forward for patients in mental health services, especially. Cool. So we've talked a bit there about some of those challenges and dilemmas that we face within our practice. I guess one of the questions is what do we think is going well, and what opportunities have we taken so far? Naheed, what's your view on that? And you're on mute again.
Sorry, I missed heart. You know what? Something happened to my technology. You know what technology is like. I heard a little bit of what you said there, Mel. You know. So if you could just repeat it.
Okay, no worries. So we talked a bit about the challenges that we've been experiencing from a social work perspective, some of those dilemmas. But I guess the question is, it's about what's going well. So what opportunities are we taking? So we've been doing this now for nearly 4 years. So what do we think is going well in this space?
I mean, from my perspective, from myself as well, you know, as a practitioner, you know, like as mentioned earlier, I came from secondary services. There are a lot of positives that is going well. We're getting the work I'm doing. I can see in terms of individuals moving forward in regards to recovery, not being stuck in a system. You know, like not needing continuing needs. The interventions have taken place. They're moving on to the next stage in terms of their recovery. You know, building might be relationship building, engaging into the community, getting back to work. You know, looking at courses, voluntary work. You know, getting into employment or voluntary work in terms of like being experts with experience, taking a lot what they've learned. And I think the positive what I've noticed as well with our interventions is working not just with the individual service user, but we've worked with individuals carers as well, the intervention. And especially it's quite a lot of individuals I work with in terms of English being a language, second language. You know, there's been a massive lot of individual language barrier, but working with individuals doing psychoeducation was such a lower level for them to understand what actually I'm noticing that what we're getting a lot is individuals coming in and saying, you know, I've been on this medication, like for example, antidepressants for years, you know, and not even knowing what it's for. You know, why was it prescribed? And that kind of work, that psychoeducation stuff work we've been doing as well in terms of educating them, you know, this is what this is for, and kind of looking at what the symptoms are, looking at coping strategies, but so at a level what individuals can understand and using interpreters, and that's like on phone and face to face, and it is very valued, and they're taking that away in terms of moving to the next stage in recovery. And I think that's always been, from my experience over 18 years, it's always been an issue. It's been quite positive in terms of having that advantage in primary care that we can actually do that work with individuals, you know, that intervention work, and definitely recognizing the stigma, the discrimination as well. So working very closely with communities as well now, you know, tapping into the communities where we know individuals are accessing schools and letting them, you know, educating individuals, you know, in regards to the stigma and interventions they can use and reduce that. So that's I think that's quite important. And I felt I never actually had that experience, that social work side in secondary services, and I'm actually feel like we've got that autonomy here a lot more in primary care, where we can tap into the community, work very closely with the community services out there.
So we are still working under the Care Act as well. So as you said, Naheed, we do have a lot of autonomy, but it's important to recognise that we still work under the Care Acts, under the prevention. So we are enabling people to address their mental health needs before they reach crisis. So people aren't on a list, as you say. We address people in turn. So it means that people aren't kind of like push. You know, you're not too unwell. You're too unwell for this, or you're not risky enough, or you know, it's kind of meeting people where they're at. And I think that's, people really value that, knowing that they've got somewhere to go to when they're struggling, and to kind of receive that support that they need. So whether it's psychoeducation, whether it's support around understanding the medication, and even just kind of basics of understanding their disorder or what their experience, I think having someone to listen and to validate sometimes might just be enough for that person at the time. And I think that's something I like to say to people, is that we meet you where you're at what stage, and sometimes that might take a step back, and hopefully we can progress, but I think that's what makes it really individual.
Definitely. And it's
So
like
we're
you're
working,
saying,
I'm sorry.
well, sorry, go on.
I was going to say that it's interesting, because I think quite a bit there, Lauren, when you were saying, is using quite a lot of health language about why would a social worker be looking at medication? Why would a social worker be? But it's understanding it through that social work lens, isn't it? So, you know, we can understand that we would ask those questions, and I'm sure that other medics would as well, people from medical, is that if you're taking a sedating medication, you say, oh, we'll take it in the morning, and then you find out actually, but they work shifts, but you know, the other way around. It's that kind of, there's a social work lens to all of the mental health language, and using the word symptoms. And I think that's when it can be quite difficult sometimes, doesn't it, for us to lose our social work flavour, but it's recognised we use a lens. So the impact of medication, the impact of having a bit from a different ethnic group, or from a family history where mental health has never been really discussed before, of course that makes things a lot more complex, and that's where social work comes and brings its own.
I think to add to that with the MDT view as well, is that so in the MDT that I'm in, there's myself and another mental health practitioner, and she's nurse-based and I'm mental health, I'm social work based, sorry. And it's that knowing who's in your team, who is able to provide. So she might do a screening assessment and actually think, do you know what, this really needs that social work lens, this really needs that area to focus on it. And it's knowing who's in your team and knowing who's able to support and what your strengths are, and kind of knowing. And as a team, it's taken us a lot to build to that point, to really know each other's strengths and areas. But actually, it's so nice to know that the people that are referred to me, or kind of I can refer to my colleague and say, do you know what, this is a lot more medical based that I'm not as comfortable with, but I know with her nursing background, she would be more comfortable with. And it's starting to kind of have that professional lens that's individual to you. So as a social worker, that's what that looks like for me and the interventions I provide, but knowing that you have the support of the others, and we have pharmacists and things like that. So all the stuff that kind of sometimes becomes too medical for the social work role, there is that support for it. And I think that's the benefit of being in the MDT, of knowing who is in your team and the support that's available.
Definitely. And I think what you, from just adding on to that, Becky, definitely. And I think it's understanding as well, we're not losing social work to an extent, are we? We are still working with the community care, right? We are, you know, we are doing that. Obviously it's not the early intervention, but we're looking at the preventative side of that. You know, we are looking at, we're assessing, we're measuring, you know, we're providing support. We're doing community inclusion, you know, promoting independence and well-being, and they are the, you know, the points of the, you know, Care Act. And that initially was in that, you know, when the Care Act came out in 1990, it's extended that to 2014, and it's still the same points that I think we're carrying on, and it's just for us to kind of reinforce that sometimes. And I think with our colleagues as well, you know, we are social workers, this is our identity, and actually these are the areas we're still working from, you know, from the Care Act. And understand, for them to understand, actually, because you will, and I've got this in my MDT, and I'm sure over in our organisation as well, you know, practitioner, nurses, etc., do actually still cover them elements as well themselves, you know, under the Care Act. That was the whole point of it, Shepherd Health and social care kind of coming together, wasn't it, really? So yeah, just definitely. Kind of just, yeah, and just educating colleagues as well, really, isn't it? You know, this is what we are, this is our identity.
Yeah, absolutely. We complement each other, and
Yeah.
it's complement each other. But I think what we
Definitely.
spent quite a bit of time on in group supervision is trying to say, yes, we've absorbed and shared identity, but sometimes we need to focus what is our identity. So you're right, that's when we've come to those questions. So just thinking a bit about how we champion and where social work sits within within the service. Becky, there's some work that we've been doing, isn't there, about encouraging others?
Yeah, I provide some supervision sessions, peer supervision sessions for the clinical supervision for the community connectors. So they're a role within our team, within our service, that are more social work led based positions without being the social work titles and things like that. They're kind of what's the word for it, kind of ethos, or I can't think of the correct word off the top of my head, and their models of working really link into that social work thinking and around kind of making sure that they're connecting the people with the community that they identify as their community. So making sure that the individual they're working with is starting to make those connections with people around them that are meaningful to them, and bringing that underneath the social work umbrella within the service allows us to support them to see the value in that, to see where those links come to from kind of different methods and models and things like that. So we're actually able to bring them back to kind of what the social work base is for those supports and those models that they're using to actually help them inform and understand that what the work they're doing and the value that has.
Yeah, definitely. And we're doing something similar, aren't we, Lauren, for another group?
Yeah, so we're going to be providing some peer kind of group supervision for the support workers. So they're going to be providing support up to 6 weeks in a 6-week model based on reablement. So it's practical support to instill change. So after that period, if the support needs remain and it's likely that they need longer term support, the people that we support, then a referral to social care will be needed. So our role will be to facilitate some group supervision and to kind of help develop their values, and yeah, in the social work way, I suppose.
I love it. In the social work way.
In the social work way.
Yeah, it is, but that's why we spend quite a lot of time, don't we, looking at what are our values, what is it? So things like confidentiality, why do we do that? We need to be skilled up in the areas that we're talking about, so making sure that our training is up to date. And we talked about having that reflective space and that supervision. So yeah, it's really important that we do those things. What other things do you think that we've really brought into the service from a social work perspective? Becky, there was something about diversity and understanding that.
Yeah, I think it was myself and Lauren that was speaking about this in one of our supervision sessions, and I think as a group we spoke about it as well. And it's about considering social work and using the values that we have and considering what makes the person themselves, and how this interacts with their lives, and actually seeing their identity within that and that diversity, and not just kind of passively kind of being aware of that, but actually making impactful changes to support them with the work. So things like neurodiversity is quite a prominent area in the work I'm doing at the minute and things like that. So I create quite a few different tools, such as kind of wellness recovery action plans or sensory profiles that support people to then be able to engage in improving their mental health. So it's that factor of not just acknowledging the issues that are struggling with the mental health, but actually, is this a barrier to them recovering, and not just giving them tools to use that won't be effective because they aren't able to address other areas, and actually understanding that them as an individual and how they access the support and how best to support them in their recovery, and actually making it that meaningful engagement in work and allowing them the ability to engage where they're able to and what they need that support with.
Yeah, absolutely. Yeah. And I think as well, it's our as social workers, we understand the impact of oppression on people. We understand how different factors affect their power, and how we understand the dynamics and how the effect on people who are ostracised. And I think if some people come to us and they're often having what we might call an identity crisis, and it's trying to figure out what is going on for you, what do you identify as? And it's kind of like stripping some of that back and looking at how they often kind of maybe conflict with each other and different values. Often what's happening to them might conflict with their values, and it's about trying to find out what their values are and, you know, developing on those. And I think just doing that work with people really helps kind of them, I suppose, just be happy with who they are and then understand the direction where they want to go in. And I think we've got that time and the space and the skills and the tools to explore that with people.
Yeah,
Yeah,
definitely.
Sorry.
No, go ahead, Becky. It's fine.
I was just going to say, as a service as well, we're actually working on different work streams about accessibility, about engage, and kind of how we're making sure that the service is accessible for different people, and actually making sure that opportunity to support is available for everyone who wants to be able to access it, and making sure that we are doing that. And that's part of that kind of diversity side of things, and ensuring that we are accessible. Sorry, Savvy.
No, it's okay. I was just going to add to what both of you, I think, touched on a little bit about how we think about, you know, people's access to care, and like we can, so one could say in like a medical model of just say is the problem behavior or something like that, to be like, for example, I've worked with a lot of patients with alcohol abuse, and you know, the expectation for them is to, okay, he has an alcohol problem, this is a problem. That is what's kind of that focused area, right? We need to fix that, kind of is where the medical model comes in. But I found that, you know, a lot of the people that I work with have issues. Yes, they know they have an alcohol problem, they know they shouldn't, you know, drink, but it's about like the accessing the right kind of care and how mental health affects their access to care at times too, especially as it relates to like if they have social anxiety about like going to groups and things like that, and how that impacts their recovery as well. So
Definitely. Yeah, absolutely. And I think it's really important, isn't it, about what the skills that we've got to be able to share with patients to skill themselves. So it's not about us telling the patients this is what you need to do. It's about giving them the time, as you mentioned, Lauren, to be able to work through that themselves within the context of their own lives and their own history. So moving on, if we look at what do we think, what's the hope then for social work within this space of a primary care mental health offer, not just in Sheffield, but we're seeing this as a developing area, aren't we, that more and more provisions coming in that gap between what was traditional secondary care and primary care. So what do we think the future looks like, or what's our hope for it? Becky? You're on mute?
you're muted.
Love it. I've still not done it. I've not taken myself off mute. That's all. That's the only reason why I haven't done it, guys. Go on, Becky.
Oh, I don't know how many chances I got left to do it. Yeah, so in terms of the future and things like that, we are, so as of next week, we'll have a social work student with us, and it's only the second student, I believe, we've had, or third student within the service overall, so that's covering all the different fields of work. So it's really interesting to be able to provide that position to explore at this early stage for a student what this position looks like, and what primary mental health, primary and community mental health will look like, and the work they'll be doing in those interventions, and building that viewpoint from the early start, I think, is a really great option and a difference of placement options. I think it provides a really good setting in understanding the interventions that we're able to provide, and not just the statutory work of kind of assessments and care planning and straight after that, kind of the speed of it. At least it gives an option of kind of exploring that a little bit earlier on and seeing the interventions that we're able to provide.
Yeah.
And also following on from what Becky said, we provide a lot of different interventions with service users who kind of come into our service. But as social workers, we have quite specific ones that we're comfortable with, that we feel reflect our social work values. So we are in the process, or we want to aspire to develop a social worker workbook with the interventions that we're comfortable with, we feel again reflect our values, and that incorporate the theories and on the evidence-based research.
Definitely. And I think just adding on to what you're saying, Lauren, it's our intervention, what we're using, but it's kind of looking at in terms of the service users we work with, isn't it? That creating them to have a bag of tools as well, sharing them tools, interventions for what they can take away in the recovery journey, and they can utilize that, when they are feeling low. What do I look in my tool bag? What can I use? What I've learned through all, through the sessions with my practitioner, what can I do to help me in regards to that? That's kind of going to what Becky said as well, about the plans, the RAP plans, the safety plans, the wellbeing plan, definitely.
And we've been discussing about where we can move into in the future, how we can expand what we do. I think this section should be subtitled "How to Make Mel's Plan to Take Over Primary Care by Social Work." But we thought that our strands, things around family life, and how to understand patients' role and change their future, oppression, how to emancipate, so working with people around that, how to start social groups. I always feel that the OTs had kind of monopolized that in community mental health, and really, back in the old days, it was social workers that ran art groups and lunch clubs and things. So just sort of looking at different ways that we can expand the service.
I could just see Mel's big smile as soon as you said that, Caroline. Do you see a big smile going on?
Naheed, go on.
I mean, I think one of the main things as well is research, using research as well. And from when I think not long ago, I brought in an article that one of my colleagues had actually carried out in terms of research, and an article that's been published now. That's my colleague from university. And that was about, the research paper was about exploring the prevalence of loneliness and social isolation. It was an analysis of safeguarding adults review in South Yorkshire. People can access that, individuals that have access to, web today as well. And that was actually looking at the impact of isolation, loneliness, and in social workers and primary care, what can we do to lessen that impact. So this kind of research is really important for us to kind of bring in our supervisions as well, like we do in our group supervision, see what we can do. And I think that already we're doing quite a lot of that work. The work we are doing, we don't kind of just stop there in terms of 10 sessions and that's it. We do look at in terms of, while we're working with individuals, not just, I'm not use the word treatment plan, but the intervention work, social work interventions we use as well. And when they move on to the next stage in terms of recovery, is that looking at what services that are out there in the community, in the voluntary sector, they can access to reduce the isolation as well and get involved in. And that's, that's really important as well. Also, and it does cover, the area in terms of the 6 principles of adult safeguarding, like empowerment, prevention, protection, all that's the 3 of them. There's in total 6, but they're the main areas we've kind of focused on, and responding to loneliness and isolation. And I think that's a big thing, and we are doing that in primary care, definitely.
And that's where that kind of community connectors role kind of comes under the social work umbrella as well. I think using that tool is an amazing resource for us to have that ability to be able to connect people to what their community is and who they want to connect to, and building that to reduce that isolation. I think it all does come under that umbrella, I think.
And so I think it's a really good example of where we used research. So where we pulled that information and we as a group went, right, this is really important, fundamental. So how are we delivering it? And I think that's where it came out around, well, actually, as our role, we should be thinking about how we support that development of peer groups where there's a gap. I've noticed in the chat, so I'm just going to pull out, there was a comment in the chat from the last person, Angela from Manchester Mind. The work that we've done, she asks here about being curious about if we work closely with the voluntary sector or the voluntary community and social enterprise workers. And we hadn't already covered that, Angela, but the community connectors are employed by Sheffield Mind in Sheffield, and the peer groups that we connect them to are predominantly provided by the voluntary sector. And we're really super excited to have peer workers, which will be working 2 days a week into each of the different teams, and there's 15 of them in Sheffield. They will be, they're provided by the voluntary sector in the model of peer work, so not in the social, it's not in fixing, it's about speaking with that person about how their recovery was for them and sharing that with the patients, the people that we work with. So there's quite a lot of work we're doing with the voluntary sector, and it's absolutely, I think, the social work theme to keep on making sure we stay true to that. Whether it's through a voluntary sector or if it's just a community small group that we're helping to set up and suggesting.
Definitely, and I think the other thing as well, Mal, and what I'm finding out, I mean, what I've found out as well, there's a lot of work, and I think we've started doing that. We've kind of tapped into that. A lot of co-production, isn't there? You know, employing, you know, experts by experience, and that is really important. And we've kind of, I mean, from what I'm getting, we're employing individuals, not just sitting on the boards in terms of interventions, you know, the experts experience, they have that input, they're having that massive input in terms of services, their opinion, you know, what is working for individuals out there, and actually coming to the lower, you know, not just sitting on, like I said, the boards, but coming down and working with us as well as practitioners, you know, working alongside, and that's where the kind of peer support, you know, peer support led group is. We've got experts experience, and a lot of organization moving toward, it's not kind of, we're moving away from that. Professionals got the answers, you know what service we need, but it's not, it's co-production and having experts by experience on board now. And I think I'm really passionate about it. I love it, absolutely love it, because you know it's so important, isn't it?
It is, and it's interesting because we've got the new those staff that are sitting in our quality team under experts by experience, and I know they're going to give me as head of service a hard time, but that's absolutely what they're employed to do, is to make sure that we are questioning how we're doing things and making sure that it's because it's patient, it makes sense for patients, not just because it makes sense to me as a budget holder and service delivery manager.
Yeah, we're going to get it down as well. It's filtered to us.
Absolutely.
Well, just like you at the top, you know. And it's going to be great working, you know, alongside individuals, you know, and getting that opinion, isn't it, in terms of our practice.
And I think one of an example from my perspective, so as I mentioned, I'm a social worker and I came into service and I still keep my registration, is that it is for me about ensuring that, I know Carolyn said I'm taking over the world. I'm trying to make sure that social work has a loud voice within primary care and mental health, and that we understand ourselves. And part of the reason of doing the event today is trying to pull together what are the competencies, what is it that makes us who we are, and I think that's key to the work that we're doing, is if we know ourselves what we're doing, then we can only be doing the right thing for patients. But one of the key motives that took me was when I was when we set up the service, we were still using this kind of referral. People were sending in the information. We were looking on a desktop at looking at notes. Oh, let's have a look what happened here, or that person did that there, and realized that the notes and what we were looking at were all written by professionals that were still using a very deficit approach. So it was, Mel can't cope, Mel has, you know, cut herself, Mel has attended A&E, Mel has, rather than talking about Mel has got a good relationship with her mother, for example, we lost some of that strength space. So introducing that part of that first contact, and when we see a request come in for the service, is that we speak to that patient, we speak to that person, what's going on for you, how can we help? And that's been, for me, as head of service and a social worker, that's my example of how we're bringing strengths-based approach into a service, and that is a direct result of being a social worker. So that's kind of cool. So we're coming towards the end, and we did have a preset question, which I'm going to open up. And then I've noticed in the chat there's somebody that kind of has an experience of working in Canada that would be, if she's happy, or they are happy to share, I'd be really keen to hear from. But if that person sort of prepares themselves, if they're happy to come onto the camera. But in the meantime, the preset question we've had was, people in the GP surgeries are often people in GP surgeries often regard social workers who have taken up the role as a mental health practitioner as a mental health nurse. So how do we make social work be valued and recognised in a primary care setting? And I'll open that up to panel.
I think one of the things I find sets us apart is our knowledge of communities, of our communities, and of the demographic group of the people that we work with. I think we understand how different factors come into play, different, again, intersectionality, how does race affect a person, how does that impact on a community, how does the community impact, and I think we understand that. And like you've mentioned before, Mel, I think we're very strengths-based, and I think that's the kind of forefront of our practice. We see people's strengths, we see hope, we're able to kind of, I suppose, not inflict hope, but kind of give people hope, and we work from that real kind of positive aspect. And I think sometimes when people go to a GP, the first question is what, not what's wrong, but they go to the GP because something's wrong. But for me, I find out when I first meet someone, I say, what's going on? I ask them to tell us what's going on and for them to share their experience, and we're not trying to fix them. And I think that for me, that's what I feel sets us apart.
I think also added to that, the discussion we had around actually being part of that MDT, and learning each other's strengths and learning each other's areas. And I think once you're working within the GP networks, GPs will start to learn the work you're doing and see the difference and the value and the approach in that. I think being part of that MDT in an open discussions around your strengths as a professional and the social work lens on it that we came back to earlier, I think pulling those sort of things in really help with that differentiating.
Definitely, and I think with the GPs as well. I mean, I'm kind of getting that quite a lot. It's not all on the systems. That little knock going down the corridor, that little knock on the door. Can I have a chat, Nahid? About this and about that. And I think that's really important. Working very closely with GPs, having that relationship with GPs as well. We are a team. Yes, we have that separation in terms of us being a team and MDT, but we still link in with the GPs, and they're linking with us, and they their email, they come down the corridor, have a chat, what do you think, what do you think? And with the surgeries as well, it's not just the GPs but other practitioners within the surgeries as well. Just thinking GPs are there are community workers in there are healthcare assistants just working with individuals, there's social prescribers, different other services within the GPs that we link in with and build that network. Definitely, I think that's really important. And working in the community, we're tapping in a lot into the community as well, in terms of looking at from what Lauren's just said, yes, about the equality, race, etc., but working closely not just with the community services, but the local mosques, tapping into the churches, schools, looking at the catchment area and what individuals need, and educating individuals on that level. And that's really, I mean, to build a foundation, the foundation is educating individuals what is mental health, and the support is available, and we're here, and it's tapping into that.
Definitely. Savi, did you want to come in? Oh, you're on mute.
It's not just me.
I can't believe it. I feel like I got it every time, but I don't. Yeah, but I think I want to really reiterate the part of that strength-based approach, because I feel like that is huge, as well as looking at, like Lauren was saying, the whole person and their environment rather than just a person existing in this vacuum, right? So I think, like Nahid was saying, that social work view can be passed on, like, by just being more present in GP surgeries, and like be willing to have a conversation with a GP or a nurse, or just like talking about their patients and the barriers that they're facing, and how a social work lens can really aid in it's like educating everyone, and it's really empowering too. So
No, we got 100% there.
100% there, sorry.
Yeah, got 100% there. So someone totally agrees. I'm going to come to Carolyn and ask if there's any comments, and then I'm going to ask Angela if she's happy to. I think she said she's happy to come and just share a bit of information from over from Manchester. And then I think there's someone with their hand up. So Carolyn, would you like to tell us what your view on that question around how do we make social work valued and recognised in primary care setting?
Yeah, I just agree with what everyone else has said. Having a presence, making sure that you form good relationships with the staff there. I always think that one of our strengths is really knowing how to make processes happen. So I'm following through, checking that the referral that I made has actually happened. I think that's something that social workers are really strong on. And knowing which services have closed and things like that, trying to keep on top of that. I think we do that particularly well. Yeah, I'm not sure I've got much to add. Sorry, Mel.
That's okay. Thank you. That's really helpful. That's been really timely. So I know we're coming towards the end. I'm going to ask Angela if she'd like to unmute and put a camera on. Thank you very much, Angela. And then I need to have 2 minutes for James, who's got his hand up, and then I'll summarise. So over to you.
Yeah, just was chipping in a couple of comments. So I trained in Canada, and there in Ontario, I lived in London, Ontario. It's very common for social workers to be attached to GP practices. In Canada, social workers can offer counselling if they follow a clinical path. So what often happens with the social worker is somebody comes to the GP practice over there, may see the doctor about a health issue, medical issue, but then will be sent to the social worker for support with psychosocial issues, which might include counselling, but might also include trying to sort out housing or benefits or things like that. So it's just a different way of the system operates. I don't know how widespread it is across Canada, and I don't have a lot of experience of it, but I do know social workers there are held in very high regard, and it's just seen as sort of a thing that happens. So I think it's really nice to see that social workers are now being attached to GP practices. I think that's a lovely thing. In terms of the project I'm involved with Manchester Mind, it's a fantastic project. I worked in secondary care for a little while as a support worker, and secondary care is very, at the moment, because of resources, crisis driven, and there's a lot of people that have to meet quite a high threshold before they get help. And I don't know how common this is, but in the team I was in, there was a really high staff turnover. So that impacted on person-centered approaches with the people that they were supporting, because it's really hard to form a relationship as a client when you're unwell if the person that you're looking to get help from is constantly changing. And also you have a limited amount of contact as well, unless you're in real crisis. So what's really nice about the project that I'm involved in is it's very person-centered. And we work with people to support them before they reach that crisis point. Somebody said that, and I think it was Nahid, and it just resonated completely. We encourage people to have their health check at the GP practice, and then if they're interested, we will offer extended support, which is 6 to 8 sessions, and it's very goal focused and person-centered, so people can choose what they want help with. So lovely. I could talk more, but I'm just conscious of the time as well. Fantastic.
Thank you,
project.
Angela. And do you know what? I'll take one for the team. I'll go to Canada, and one of y'all can go to Manchester. Are we all right with that, guys? It's wonderful to it's wonderful to hear, Angela, and no doubt, yeah, please get in touch, because we'd love to hear more about both your Canadian experience, but also what's happening over in Manchester. So guys, James has just let me know that it's okay for us to just summarise and close, because we've got 1 minute. Well, for me, that hour has just flown by, and I've had such a great deal of fun. So thank you to everybody. I hope that what this has done has given everybody a bit of a flavour of what social work in primary care looks like for mental health, what the things we've been tackling and what we've been grappling with about understanding our identity as a professional group, and about what our futures are for the future, and the things that we feel that we're really proud of that we're doing well. So thank you so much for joining us during Social Work Week, and we hope that we've really contributed to your understanding. And if any of you would like to come and get in touch with us, please do. And yeah, speak soon. Can I have the final slide up, please?